Hello and welcome. My name is Donna Cryer, and I am the CEO and founder of the Global Liver Institute, and I have the privilege of being your host for GLI Live. And this month has been a fantastic opportunity to reach out to our friends in the kidney health space. And it's probably a little known fact of how closely the liver and the kidneys work together clinically within your own bodies, but also how closely our organizations work together on policy initiatives, which will be the point of our discussion today. So with me, I have an all-star cast, so I'm really excited, and this will probably be the last you hear really from me if this all goes as planned. We have many of our friends from the policy shop at the American Society for Nephrology, which is really the premier medical society. Nephrology is the study of the kidney, and so they'll explain more. So kidney health, renal health, nephrology, all the same bucket of things for our lay listeners in the audience. So I have with me David White, who is the ASN head of regulatory officer. Rachel Meyer is Senior Director of Policy and Government Affairs, and Zach Kribs is Senior Government Affairs Specialist. And then I am particularly excited to bring to the GLI Live stage our own Andrew Scott, who is the Global Liver Institute Director of Policy, and in his short 2 years with us has really been instrumental in transforming the trajectory of what the liver community has been able to do from a policy standpoint. And so, hello, everyone.
Hello.
Fantastic. So, Rachel, let me start with you. So tell us about ASN and what you do and what your policy agenda is.
Well, thank you so much, Donna. It's a pleasure to be here this morning with you and Andrew. And I think as you articulated, today's chat is really a reflection of much of the collaborative work that ASN and GLI do the other 364 days a year that we're not here on the GLI Live feed. So really looking forward to today's discussion, and thanks for the opportunity to get to know your community a little bit better. So in terms of ASN as an organization, it's the largest organization of kidney health professionals. So this is doctors, scientists, other health professionals who are really dedicated to treating, studying, and ultimately to curing kidney diseases. So since the focus of our discussion this morning is really on advocacy and policy priorities, I thought I might open by sharing just some statistics about kidney disease that I think really drives and motivates the ASN membership, the leadership, and underpins our advocacy agenda for your audience today. So globally, more than 850 million people are affected by kidney diseases. And here in the US, there's about 37 million Americans who have kidney diseases, about 500,000 of whom have progressed to total kidney failure. So what we're really dealing with here is an under-recognized public health epidemic. And I think, unfortunately, like so many of our other public health crises in this country, certainly including the COVID-19 pandemic, and we'll get to that more, kidney disease also disproportionately affects underrepresented minorities and communities of color. That's an issue that ASN has long paid attention to that I think is really, in 2021, particularly driving our advocacy agenda. Just to take one example, close to 60% of people who are on dialysis are people of color. Diving a little deeper, about 13% of the US population is African American, and yet 33% of the people who are on dialysis are African American. So you're seeing a very disproportionate burden there that I think is emblematic of some of the challenges that the kidney patient population faces, and also some of the policy solutions that we're looking to drive this year together with the broader kidney transplant community, including GLI.
Let me take a moment and just speak to that, because it is so dire, and many liver patients don't realize that because of our immunosuppressants or because of our underlying diseases, many of us end up on dialysis or needing a kidney transplant after a liver transplant. And so, we can't ignore kidney health. So often, we may be, focused on our liver enzymes, but, you go a few lines up or down and look at things like creatinine and EGFR and BUN. And I think it's very important that liver patients understand their kidney numbers and health, and that kidney patients look at their liver numbers and health, because they're so very interconnected. And when we look at the transplant list overall, the kidney transplant lists are predominant, but we can't meet the current need for transplants for either kidneys or liver patients, and so we have to do more and more to prevent the development of either.
And Donna, I'm so glad that you brought up the importance of both kidney patients and liver patients paying attention to their stats, which really are interconnected in terms of the health of those organs. One of the things that ASN has been focused on, in addition to health equity for quite some time, is prevention. And I think that's a theme that you'll also be seeing in our advocacy agenda for 2021 and moving forward. I think I just articulated a lot of kind of tough realities that we as a community have to acknowledge: the public health burden, the health inequities, especially in terms of prevention, and more recently, a pandemic that's exacerbated both of those trends. So in 2021, we're really focused on healthcare justice, prevention, and kidney health, as well as an increased voice for patients as we expand their kidney health choices and options. And that emphasis on the patient voice is one of the reasons we're so proud to continually partner with GLI in our efforts.
Well, we certainly appreciate it. We certainly appreciate that. Yeah. And we have many members of our GLI Advanced Advocacy Academy who have both liver disease and kidney disease, myself included. And so being able to talk to both when we're with policymakers, I think is a very powerful thing, more powerful than doing either alone.
Yeah. That is certainly our philosophy at ASN as well, is that to the extent that we can collaborate with others, particularly with patients, our messages are going to be stronger and resonate more than either of us could possibly be as individual actors.
Fantastic. So Zach, I know that you and Andrew probably cross each other, well, in the before times would cross each other on Capitol Hill, at least once or twice a day. How have what have been some of our joint success stories as we have moved to virtual advocacy?
Yeah, no, thank you. And I definitely miss those days of crossing paths randomly in like the House and Senate tunnel hallways there. And I think that's actually a really interesting point too. And Rachel touched a little bit on how the COVID-19 pandemic has really exacerbated a lot of these disparities and really created a new sense of urgency. And I think it's also created some new actual challenges too, not only in the way we do things, but in some health issues. As you may be aware, kidney patients are, especially those with kidney failure, are at increased risk for the COVID-19 pandemic and can face, if infected, much higher rates of severe infection and mortality. And in addition, we're actually seeing evidence that the virus causes kidney damage in otherwise healthy patients. And I think in some cases it's been around 30% and can be even as high as 50% in some places. So we're looking at this huge, potentially this huge increase of individuals really developing issues with their kidneys for the first time. And that's something we're really conscious of in our advocacy.
So why can't we get vaccines? So, dialysis are, they're going in many cases, 3 times a week. They're identifiable on a list, connected to care, easy to reach. Why aren't they prioritized for vaccines? You've talked about the risk, even to people who had previously not had kidney disease, turning them into kidney patients. The same for many who are converted to liver patients by COVID. Why aren't transplant centers, for example, who have their lists of patients, easy to reach, easy to identify, very high risk, as shown in the data and the science? Why can't we get our patients vaccinated? What is not resonating with policymakers and those who put together prioritization?
Well, go ahead, Rachel.
Yeah, right.
We're all smiling for the same reason.
You can sense our passion on the ASN side for this topic, just as I know you all at GLI are passionate on the subject as well, Donna. So I think we have been fortunate in that through ongoing conversations with the Centers for Disease Control and Prevention, and more recently the White House, our sense is that there is a lot of recognition about the unique vulnerabilities of this particular patient population who are on dialysis, as well as, to your point, individuals who've received a transplant and are at higher risk for COVID-19 infection. So it's certainly a top ongoing advocacy priority for ASN. Our ultimate hope, our holy grail, would be to receive an allocation that is directed to dialysis patients, much like the transplant center analogy that you just articulated, because people who are on dialysis are going to a unit typically 3 times a week,
right,
where they have a very trusted care environment that is adept at giving vaccines, such as
right,
influenza. There is kind of a ready-built infrastructure. So while we're still hoping that the Centers for Disease Control and the White House can deliver an allocation or otherwise support that patient population directly, the positive news is that many individual states, including where I temporarily am in New Mexico, are beginning to prioritize people with chronic kidney disease as a condition. I think, from an advocacy standpoint, the most important thing for both ASN and GLI is to sustain our efforts on behalf of the patients that our members serve and that you all represent, and not let up on policymakers at the federal level. It's great that states are beginning to prioritize this, but I think action from the top remains necessary, considering the vulnerability of, again, the patients that our members serve and who comprise the GLI membership.
I'd like to add just one thing on that, if that's okay.
Go ahead, Dave.
Yeah, no, it's because Rachel and Zach have already kind of referred to it, and we've already talked about some. This pandemic has laid bare the discrepancies, the disparities, all of the things that have happened for so long now in the system, and how to get a hold of that is going to be challenging. But at least I think the one silver lining in this is it's no longer something that it's very credible to stand there and say, oh, that doesn't exist. Oh, it does exist. And Rachel and Zach and myself have really, along with many other people in the community, have done everything we could to try to make that federal allocation happen. But we all know the vaccine has been limited. There's been politics involved at times. There's a lot of interest by governors to just take over and to make this happen. And it's just one of those things that I think there's a lot to discuss as we move past this point, about how things went down and whether or not it was the right way. But it really has been truly an eye-opening experience of things that I think a lot of us knew were part of the fabric of society, or just laid bare. It's just hard to deny them. And that I think is the silver lining, and something that, I very much feel strongly about, that it's really a good thing. It's, so
Absolutely.
I'll stop there.
I use a phrase that Andrew knew as well in the conversations about disparity. I say, don't be tacky. And there's often the inclination to sort of tack on, a diversity or a social determinants of health or health disparities program sort of at the end or over there or for a short period of time. And I think we've realized that it has to be woven into the essential fabric of how we think about every policy and every aspect of healthcare. And so,
Absolutely.
Yeah. Let me let Andrew in here. So, Andrew, you have been not only a fantastic, translator of my frustrations and angst and sometimes anger over how things have been done, and you polish them into beautiful political prose. And so tell us about the momentum and the progress that we have made, because we have shifted some priorities and discussions and past different pieces of language. There's been a lot of movement, and I want to give you the opportunity to talk about that.
Thank you, Donna. And you're exactly right. I mean, obviously, as David and everyone has mentioned, it has really laid bare a wide variety of issues that we've all been well aware of and been fighting to change for years. But I think there have been some of those wins, and I know Zach will touch on one momentarily here that was a big one. But even from the COVID perspective, initially, and I'm sure we all remember, transplant recipients were not even prioritized to be tested, receive their COVID-19 test early on. And that's something that we all advocated to change. And thankfully it was changed, within those first few weeks of the pandemic. So that was obviously an early win. I think we still have a wide, a lot of issues still to accomplish. But outside of that, also, there is a big ticket item that we've all been working on. It started initially in even before 2019, but the initial kind of success happened in 2019, and that is OPO metric reform. And that's something I think we've all been advocating for. Specifically, how can we improve our organ procurement system, and that in turn can hopefully lead to opportunities. Thankfully, last year we saw kind of some initial success to that with HHS kind of finalizing the reform measure. Of course, we're still advocating currently with the administration to move forward and urgently implement it. But that is something I think we continue working together on, and that was a success we saw kind of during this COVID pandemic. And I'm going to turn over here to Zach in a second, but I think that really underlines the point that there is no pause button for the variety of these issues that we're fighting for, even during COVID, right? We have to continue fighting for them. We can generate real wins and hopefully cause change, even as everything else is going on in response to COVID. And I think that specifically leads into a legislative win as well, Zach, and I'll turn it over. And this has been a bill that has been really advocated for. We and you all have been advocating for years, and we're happy to see success at the end of last year. Go ahead, Zach.
Yeah, thanks, Andrew. No, that's a really great point. And really, we do. I think, Donna, your point about making sure that our focus on disparities is the focus and not a tacky issue is really germane and such an important thing to keep in all the back of our minds. I mean, I know certainly we're looking at kidney transplant patients. I mean, non-white transplant patients really face barriers, I think, in every step of the journey, whether that's like evaluation to waitlisting to the quality of organs you receive. And that's really become a central part of our advocacy as an organization. As Andrew's mentioning, there's this really fantastic piece of legislation. It's got a very long name, so bear with me. It's called the Comprehensive Immunosuppressive Drug Coverage for Kidney Transplant Patients Act. And that was of 2020. That was passed last year. And just as like COVID has been really causing some struggles in the operations of Congress and the way we do advocacy, I think it's no secret that Congress is also facing kind of an unprecedented period and kind of how they work together. And this is really one issue that had immense bipartisan support, I think similar to the OPO metric reform issue, which is kind of really heartwarming to see. I mean, in the House, for instance, it was led by Dr. Burgess, who is a deeply conservative member, and yet you also have like very liberal champions, Jerry Nadler in the House calling for this. So like this is a really kind of impressive group of folks that kind of came together. And basically what this bill does is it before this legislation, Medicare would pay for your immunosuppressive drugs for kidney transplant patients for a small window of time, 3 years. And then after that, you're really on your own. And I think there was, we talk a little bit about donut holes in terms of coverage. There was definitely this donut hole where folks weren't able to get private insurance, but weren't also able to qualify for whatever reason for continued Medicare coverage for their immunosuppressive drugs. And and so they would often ration these drugs, go without them, and ultimately could result in the loss of their organ, which is just like such a huge travesty. And not only is it bad for the patient, it's also nonsensical from a taxpayer's perspective, because the individual would then go back onto Medicare for dialysis, which is even more expensive than a transplant. So really, because of this bipartisan leadership, we were able to get this bill across, which we were very excited about. I think a version of this policy had been introduced every Congress since Ronald Reagan was president. So really glad to see this period of historic momentum, even despite everything that's going on.
Yeah. So,
and I think it's energy sorry,
I'm going to give a little policy history here, and David, maybe you can back me up on this. I was in federal affairs basically with UNOS when we were able to get it from 30 months to 36 months, and there it stood for 18 years until I came back around. I had 5 other careers. Came back to start the Global Liver Institute, and we were at the same place. And to see that then move, so deeply gratifying for me. Of course, the ESRD program and the coverage for immunosuppressants for kidney patients is a unique artifact of history. And I think, we had always thought that it would, extend to the other organs for transplantation, but it has not. And so, one of the things that I think we need to work on is how can we, since the ESRD program also makes it very easy to quantify when there are gaps or losses or impacts or changes in the interventions for kidney patients. And since we don't have that type of reimbursement system, we can't have that same type of economic analysis for liver patients and liver transplant recipients. And so, David, help us forge a path to better coverage and care for liver patients. Based on, we're never going to get an ESRD patient, program for liver patients, but how can we perhaps learn some of the lessons and take some of the positive outcomes and the information about how it does save costs to deliver better care to people and to give them their immunosuppressants and to keep them healthy. What can you teach us and give hope to liver advocates that we can do right by our liver transplant recipients?
Well, that's a big order. That's a very big order, and I hope my colleagues will come to my rescue if I mess this up. Because, and the first thing I'll say, and it's not meant to be flip. It's just that I know that there are many of our members, leaders would say on that one, they'd say, be a little careful what you wish for. Mm-hmm. The ESRD benefit has been fantastic, and yet at the same time, it has had a double-edged sword to it. And so, yes, you're right, and liver patients definitely could use this type of support. I mean, I don't even think that they know that you're talking about billions. You're talking 36 billion a year just for the ESRD program, and then in Medicare alone, just overall 120 billion on kidney diseases. That doesn't go into the other programs. That doesn't go into the Veterans Affairs. That doesn't go into Indian Health Services. That's just Medicare.
Right.
So it is important. I think as we look at this, what we would want to do is be careful not to replicate the things that happen, which is that it kind of set up a situation in which you could really, an industry developed, rightly so, because they needed it to do dialysis. And it became a default, and the money and the priorities and the incentives went there. Mm-hmm. And it really kind of stifled research and innovation, both in new types of products and also care delivery. So that's something I think will be really important as we talk about going forward and things that liver might do, that I think they could really benefit by kind of looking at some of the things that came out of the ESRD program that probably are not what you'd want to replicate, although lots of great things did come out of there. The one thing that we do know is CMS is quite good at setting up a very large comprehensive system. They may drive us all a little nuts sometimes, but they're like the Army. They showed up and they made it happen. And so we do have a lot there, but you can look at that. And I know you probably have a similar version of ESRD networks that help in for kidney failure patients. You have a version of that. I think somewhat in liver. I'm not sure completely, but how we would maximize that. There's going to be a lot of that and a lot of building across. Rachel, I see you got your mic off. Jump in.
Well, David, I think you delivered a really important message. The ESRD program has been, for millions of Americans and their families, a life-saving lifeline. I think interestingly, and this is probably where the liver community is also thinking, some of in the last decade, I think key findings of the last 40 years of this program's existence have really come to light. And that is, as David said, rather than focusing our federal resources and resources as a kidney community on the end stage of the disease, ESRD, hence the program name, that it's really time to, as a community and as the federal government as the primary payer, open the aperture, if you will, on kidney care and kidney health, and begin to, at the federal level, investing in things like earlier detection, slowing the progression of kidney diseases, and for people who do progress due to their kidney disease, or in the case of the GLI community, their liver disease, identifying ways we can give patients more options for their care. So in kidney, some of the things that we're really focused on as a community and in partnership with CMS and the Center for Medicare and Medicaid Innovation are things like, how do we make transplant first a reality, not just as a clinical goal, but also as a goal through the payment mechanisms and the quality metrics that are used in the ESRD program? How do we give patients who want to do their dialysis, for whom that's the best choice, at home as opposed to in a center? So I think beginning to open the lens beyond just looking at coverage for people who've kind of reached the end of the line with their organ health, and looking upstream to, and this includes a financial perspective, looking at how do we preserve that kidney health or that liver health for as long as possible, and then giving patients choices once they do get to a point where organ replacement therapy of some form is necessary.
Right. Andrew, we've done a lot of work together on both prevention, particularly in things like our U.S. NASH Action Plan, and in the value of stopping progression, in messaging to our regulatory colleagues. Do you want to speak to some of those activities?
Sure. Yeah. So, I mean, obviously a variety of initiatives that we're working on that are very much touching on that perspective. I from the regulatory side, as Donna mentioned, we of course make that point to our the regulatory agencies, the FDA. But I think another point, just from again, I'm always going to have to bring it back to our federal policy side of things. Medical nutrition as well. Looking at ways to kind of head off things before they progress to a point that require a transplant. Obviously with NASH, when we're specifically talking about fatty liver disease and NASH, the goal needs to be stopping progression, or at least slowing it down, so that we can prevent getting to the more expensive, very expensive and burdensome procedure of liver transplant. So that's where, when we're talking about options that include, intensive behavioral therapy and, making sure those therapies are covered and things like that, that is obviously a key pathway that we are obviously advocating for as well.
Key aspects of that, in addition to nutrition and really standardizing what lifestyle intervention means for liver patients. Is it the same as for diabetes patients and things that were proven in the diabetes prevention program? But because diabetes and fatty liver disease in particular are so concurrent, awfully fine together in the same patient, it's so important that we think through nutrition, movement, lifestyle interventions, weight loss medications, bariatric surgery, and really give access to dietitians and everything to give people all of the various tools and also greater coordination across their various specialists to ensure that they can stay, to your point, Rachel, about being screened and just identified to have early stage diabetes, chronic kidney disease or liver disease, being able to have all the tools to intervene, and just there's a value of just staying stable there at those, early and mid stages, and preventing that progression to the late stages where the physical complications and but also the economic costs start to weigh in when you're talking kidney or liver transplantation or cancer, and other things. So really working together on so many of things that are common to our patients, and can be put together in a great care package to address all of those elements.
Well, and on that point, Donna, I'll let David speak to this, since he and ASN's quality committee really lead the society's efforts here. But we are so thrilled to have two new models coming from the Center for Medicare and Medicaid Innovation that do emphasize these exact themes that you were just talking about. And we're optimistic that they can, that they will succeed, and that they can also lead the way for other chronic disease areas to have similar models of care. David, do you want to talk a little bit about the models and kind of the economic analysis that we would come out of them? Patient outcomes, of course, being the number one most important driving factor there.
Well, just and please stop me. Just hold your hand on it if I get like down in the weeds and you're like, oh, please stop that. That's you're like, oh my God.
This is great. No.
We have two payment models that have been proposed and are moving forward in CMMI that were years in the making. And they really kind of go to this whole conversation, and hopefully that they will be useful and provide, evidence and the science to back up many other reforms of this nature. One of them we call the voluntary model. It's the ESRD treatment choices model. And that one, it has a group of nephrologists and patients in dialysis facilities, about 30% across the country included in them. And that is specifically to try to increase home dialysis and also to increase early transplantation, preemptive transplantation, and how to go about that. There is also a program that we are trying to monitor very closely that will be set up trying to do a kidney transplant learning collaborative. And hopefully that will have value that can extend beyond just kidney transplant in this model to help support them. Then there is a voluntary model, which is called the Kidney Care Choices model. And that one is designed to go upstream. So therefore, currently, nephrologists get a monthly capitated payment for dealing with people who are on dialysis. This creates one to deal with people who have not ended up at kidney failure, but have kidney disease, trying to stop putting all the money and incentives at the end stage and get upstream, which, and as you said, the things that we talk about, there are so many things that are intertwined here between liver, diabetes, kidney, and when they start to go shut down and not go well, they're going to take those neighbors with them in the body, so to speak, and they're going to do that. I was just going to return to something that just really kind of strikes me of the challenges we're facing. Coming out of COVID, we had a tremendous success in something very new. Telehealth. It went from being this teeny tiny little infantile thing to being huge. And everyone said, well, that's fantastic. The problem is that, and it is, I think, fantastic. The problem is, as everything else we said, it laid bare another, inequity, which is those communities that do not really get to go across the digital divide and do get left out. So once again, we found a solution, and guess what? More affluent people and more white people were able to access it. And that can't be the way we do this. My public health message, and then I'll let the rest others go, is they all know I can't help but do something like this on this thing. They know I'm a big Star Wars fan. I'm also a Star Trek fan from the original.
We'll that out, we'll battle that out as to which one is.
Okay, all right, Ferengi or which one you're gonna do? Okay. Or Mandalorian. But the catch is that I'm going to be cheesy, and I'm just going to say it. Public health, and I think we are in a place with this administration and with advocates like GLI, that public health, it's time for this ship to go into places it has never gone before. to seek out new people who have been left behind and to provide new services where there was not a lot of hope. And I think it's time for public health to become as important as anything, as defense, as education. Well, I shouldn't say education because we need to make that more important sometimes too. So that's where I am. I'm gonna beat out now.
I am there. Captain, I'm there with you. So, Zach, another area that we have been successfully, collaborating that impacts both of our communities is living donation for transplants. And so, tell us about the progress of some of the, and that's based on some, very innovation. They weren't doing that back when I was, being transplanted. That didn't even exist. And so, living donor protections. Tell us about that legislation.
I'm so glad you brought that up. Yeah, I think one thing that strikes me too is we're talking conceptually about moving more upstream and doing more preemptive transplants. Living donation is often really one way to really help fill that gap. I think at any given moment, there's about 100,000 patients with kidney failure on the transplant wait list. A new patient gets added about every 15 minutes. And really sadly, every day, about 12 patients on the kidney transplant wait list die while waiting for a transplant. So there's really this immense organ shortage for kidneys, and I'm sure there's a similar shortage for livers. But living donors can really help fill that gap. They're treated by our system a little bit separately than the deceased donations in that whole process. It provides better quality of life and a longer lasting transplant in many cases. But we also don't make it easy for living donors. I think the statistics are like 1 in 4 living donors. So people who have already gone through a donation have expressed difficulty, significant difficulty obtaining life, disability, and long-term care insurance, or facing like price discriminations. There's a lot of concerns about employment. I believe the last study I looked at said that on net, in order to donate an organ, you as an individual donating are on the hook for around like $5,000 on average. And I need to double check those numbers, but the disparities in who can give, and particularly for kidneys where you need a 6 antigen match or would like to have a 6 antigen match, to have someone of a similar genetic profile is usually helpful. And so if you can't afford to give, if you have to pay for the privilege to give this gift of life, that's going to exclude a lot of people. And we want to make it at least neutral for everybody to be able to, who's willing and wants to be a living donor, to be able to do so. I think another important aspect about living donation is that in some ways it depends on the size of your social media network and your Twitter followers and Instagram prowess to be able to find and bring in your own donor with you. And we aren't doing enough to make it easy and to do exchange programs and to identify and match living donors. So how successful you are at this living donation, which does have better outcomes, isn't dependent on how many siblings your family, your mother and father had the foresight to have, or how good you are on Twitter. And so I think solving that disparity on the donor side, as well as making sure that those who do step forward don't have to pay an additional price for it, is so important. Yeah, we have to remove all the barriers we can, and I think we see this in the data reflected. Black patients are 50% less likely to receive a living kidney donor than white patients. And similar disparities exist for Hispanic patients as well. And we don't make it easy. We put all these barriers up in front of living donation. So one piece of legislation I'm really excited about is called the Living Donor Protection Act. And this would make it illegal for life, disability, and long-term care insurance to discriminate against one status as a living organ donor, and that goes for any type of organ donated as a living donor. And it would also codify that the Family Medical Leave Act covers, would ensure that if you take time off to donate, your employment is still in place till you recover. And so that's another longstanding priority of ASN. And I know a number of advocates in this community, and we're really hoping we can use the momentum on the Immunosuppressive Drug Coverage Act to finalize this. Rachel, I'm sorry, it looks like I was cutting you off there too.
I could have this conversation all day. This is fantastic, and it just points to the power and potential of our partnership. But I am going to have to do sort of a last round robin of either points we didn't quite get to on this one. Maybe it was as a setup for our next conversation. But definitely things that we want our audience to take away. So I'll go Andrew, Rachel, David. Andrew?
Yeah, thank you, Donna. So I think obviously, as we discussed, there's a lot of opportunities here, and the through line is really there. And I think that's why, as we go forward in this year and beyond, we're going to continue working together. Obviously, there's one thing I wanted to mention, and we talk so much about, the prevention, which is obviously so critical in the public health side of things. But at the end, when we're talking about living donor protections and the Living Donor Protection Act, there's another point that I hopefully look forward to discussing more in the future, but that is the idea of a perfect organ. That is a barrier in itself, right? So when we look at all the things we're doing to increase the number of available organs, whether that means improving OPOs and the opioid metric reform that we briefly discussed earlier, the Living Donor Protection Act, and increasing the number of available and minimizing the wait list. The idea of having a barrier in itself of a perfect organ is something that obviously I think very much both of our organizations are in line of how we can possibly fix it and work together to kind of move forward on that. And the perfect recipient too, as David just highlighted as well, in a message. So I mean that's there's a lot of opportunity there, because that in itself is creating barriers that we can hopefully work to eliminate in the future. So again, so much opportunity. I don't want to take too much time here, but it's exciting about the possibilities for the future, and I think that's a point worth mentioning.
Great, Rachel.
Yeah, Andrew, I absolutely share your optimism. Particularly now that we have a Congress and an administration who are so aligned with the lens that ASN and GLI have been viewing things through, that of health equity, for quite some time now. I think a lot of GLI and ASN's success has historically and will continue to derive from having the courage to acknowledge that despite the many, many successes of the transplant system, that we can and must do better than the status quo. It starts by defining where your faults and opportunities for improvement are, and by remaining focused on how, by overcoming those, we can improve the lives of patients. But I think taking that first step to having the courage to say, this is where we can do better, is where ASN and GLI have succeeded in the past and will continue to moving forward.
Fantastic. David?
I'll just say that the outstanding organ procurement organization metric rule had gotten finalized, but because of the timing when the new administration came in, it got a second review. We are looking at that as simply a matter of the transition from one administration to the next. We look at the really strong, transparent metrics in the OPOs as where we want to start. You got to, as the old Confucius saying goes, the journey of 1,000 miles begins with a step. Well, GLI and kidney patients and liver patients have been on this journey many times, but for the moment, that's where we're going. We're going for the organ procurement organization metrics to go, and then we're going to have to address the issues of why we have to have perfect organs and perfect patients and all the other underlying things that can kind of snafu people's ability to donate and to receive.
I think that's absolutely fantastic summary. And so I hope everybody who has listened to us shares this optimism, shares this sense of purpose. I want to thank all of you for allowing me to, use this opportunity of Kidney Health Month to talk about our connections and collaborations. And I just want to really state what a wonderful partner ASN and all of you have been, how your president Todd has been to me, as we now partner on the board of the Council of Medical Specialty Societies. It's a joy to spend time with him there. And I just look forward to continuing this push for the best possible care and the best possible outcome for kidney and liver patients and their families, which will benefit all of the communities and the health of the American public. So thank you all for being with me today, and thank you all for listening. For more information, you can find us in other episodes at globalliver.org and on Twitter and Instagram. So have a happy St. Patrick's Day, everyone, and we'll see you next time. Be well, stay connected.
Thank you.
Thank you.
Bye.
Thank you so much.
Thank you.